Hi everyone, welcome back to LipidCurious, an educational platform focused on simplifying lipid management for clinicians. I'm your host, Dr. Vishnupriya Pulipati, a board-certified endocrinologist and lipidologist. In the last episode, I introduced a LipidCurious project called How to Assess ASCVD Risk Stratification and Optimize Lipid Therapy. I originally planned this as a formal course, but as I was building it, I realized this framework would be far more useful if it were widely accessible. So instead of a formal course, I decided to release this as a focused 3-episode podcast series. My goal is simple: to give you a repeatable, evidence-based way of thinking about ASCVD risk and lipid decisions that actually work in real clinic time. There are different ways of doing the same thing. If you already have a system that works well for you, that is awesome. If you manage adult lipid disorders, review lipid panels every day, and sometimes unsure what to do next, you're in the right place. Today, I want to walk you through how I approach the ASCVD risk before I ever touch a risk calculator. Let me start by addressing the elephant in the room. ASCVD risk stratification often feels confusing and overwhelming. For a long time, I felt that way too. But here's the key point. The confusion isn't because the science is weak. We actually have a lot of high-quality guidelines. The problem is that we have too much of it. Multiple guidelines, overlapping categories, different terminology, and plenty of exceptions. And on top of that, most of us aren't just managing lipids. We are managing diabetes, blood pressure, thyroid, obesity, often all in the same visit. Lipid decisions may get 2 to 5 minutes at best. So the overwhelm isn't just about the knowledge, it's also about time and the lack of simple, usable framework. When many clinicians reached out to me about this topic, they weren't asking me what do the guidelines say. They already knew that. They were asking me which one do I use and how do I apply it to the patient sitting in front of me. That's exactly the problem this framework is meant to solve. For this series, I primarily use the 2018 AACE cholesterol guidelines as my foundation. I find it well structured and practical for day-to-day decision making. Guidance from other excellent societies such as American Association of Clinical Endocrinology, National Lipid Association, and American Diabetes Association is layered in where it adds clarity or fills the literature gaps. The goal isn't to compare the guidelines, it is to use them cohesively. This is an LDLC-driven prevention framework. We are not diving into pediatric lipid disorders, triglyceride pathways, genetic syndromes, etc. These topics matter, they're just outside the scope of this series. This is going to be evidence-based, but not evidence-exhaustive. We are not going to go through every trial, nuances, or rare cases. The goal is to make this content useful for real-world clinical decision-making. In this episode, we'll focus on 3 things. 1. The purpose of ASCVD risk stratification. 2. Where I start every single time. 3. The 3 questions that guide everything. If you haven't already, I recommend exploring the complimentary LipidCurious starter kit at lipidcurious.com. It reinforces many of the concepts we'll discuss today. All right, let's get into it. What is the purpose of the ASCVD risk stratification? It helps us identify who benefits most from treatment and who doesn't, match treatment intensity to an individual patient's risk, promote consistent and equitable care among clinicians. Risk stratification is not about labeling individuals, it's about making better and often life-saving treatment decisions. So, where do I start every single time? If you know me already, I always start with the basics. Let's start with who to screen, how often, and what to order. Who to screen? All adults aged 20 or older should be screened for lipid disorders. Some societies emphasize on screening between the ages of 40 to 75 because the evidence is strongest in these age groups, but most societies encourage screening above the age of 20. How often? at least every 5 years for most adults. Consider annual screening if there's a family history of premature ASCVD, patient already has a pre-existing ASCVD or major ASCVD risk factors, or it's a middle-aged adult with evolving risk. Screening frequency should reflect risk, not just the age, in my opinion. I think the family history here deserves a brief pause. Premature ASCVD is defined as events before the age of 55 in men or 65 in women. Family history is considered as first-degree relatives such as parents or siblings. But in real clinical practice, it's not as clean-cut, right? So if I hear about multiple early events clustered on one side of the family, I take that seriously too. Guidelines help us with guidance. They don't replace clinical judgment. Okay, next up. What do we order? I start with non-fasting lipid panel for most of the patients as a screening test. I switch to fasting if the triglycerides are more than 400 milligram per deciliter. I suspect a genetic disorder. Patient recently had a super high fat meal, or they have a strong family history of ASCVD or dyslipidemias. I usually just start with the basic lipid panel. To refine the risk, I may add on non-HDLC, ApoB, or lipoprotein little a. All right, next up, the 3 questions that guide everything. Before I ever open a risk calculator, I ask myself 3 questions. 1. Is there a clinical ASCVD? 2. Is the LDLC persistently more than or equal to 190 milligram per deciliter? 3. Is the patient 40 to 75 years with any type of diabetes? Yes to any of these, I'm already thinking about treatment. So in simple words, this is literally how my brain works in clinic. Patient is sitting in front of me, the lipid panel is open, something looks abnormal in there. I pause and ask myself, do they already have a heart attack, stroke, or peripheral vascular disease? No. Is their LDL randomly more than 190 milligram per deciliter? No. Are they 40 to 75 years with diabetes? If yes to any of these, I think about treatment. Simple? So let's focus on question 1, clinical ASCVD. What is defined as clinical ASCVD? I find it easier to go by the organ system. So there are 3 organs, brain, heart, and blood vessels, right? From the brain standpoint, TIA or ischemic stroke. Heart is myocardial infarction, stable or unstable angina, or previous revascularization such as stent or open heart surgeries. Peripheral blood vessels, aortic aneurysm, claudication with an abnormal ankle brachial index, history of amputation, or stent or other procedures in the lower extremities are considered peripheral vascular disease. So if a patient has any of these conditions due to atherosclerosis, it is considered as clinical ASCVD. Whenever I decide this patient has clinical ASCVD, the starting point in my brain is high-intensity statin. We can consider moderate intensity statin if their advanced age, above the age of 75, can't tolerate a high intensity statin, or they have an ischemic heart failure with reduced EF, based on some literature out there. But conceptually, I always start at high intensity statin in my mindset. Now, some guidelines use different terminology like very high risk, extreme risk, different words which can feel confusing. I always wondered what difference does it make what we call them, because we're going to start with high intensity statin anyways, right? The distinction isn't about what you start in this patients, it's about how aggressive you need to be after you start. If someone is a very high risk, you will be very aggressive rather than waiting for lifestyle changes to take into effect. Here's how I identify very high risk. More, recent, or systemic disease, it's very high risk. Let me repeat that. More. If they have more than one ASCVD event, they had a history of cardiac stent and now they have a peripheral vascular disease. That's more disease. Recent. If they had an event within the last year, if they had a stroke 3 months ago, yeah, they're at very high risk for a recurrent event. Systemic. Comorbidities which are ASCVD risk, such as age more than 65, diabetes, hypertension, chronic kidney disease, active smoking, or LDLC more than 100, which is poorly controlled. These are all risk for very high risk for ASCVD, right? Next up, Question 2, LDL-C more than or equal to 190 milligram per deciliter. If they never had a heart attack, stroke, or peripheral vascular disease, then I'm looking at the LDL to see how it looks. If the LDL is more than 190, do not touch the medication yet. I want us to pause and think about, is there anything else making the LDL look like that? What I mean by that? Diet. There are some severe carnivore diets or keto diets where the LDL is very high. Medications, some glucocorticoids, anabolic steroids, diuretics, beta blockers can cause the LDL go high. Hypothyroidism, kidney problems, liver diseases can also cause it. So the basic way I do is I ask them about their diet, I look at their medication list, I do a thyroid and CMP. That's all you need to do. If these did not reveal any obvious causes, then this is a severe primary hypercholesterolemia hinting towards a possible genetic cause. And probably they were living with this high cholesterol for a long time along their life, right? So just like a clinical ASCVD, the starting point for this condition is high-intensity statin. Next up, question 3. Diabetes between the age of 40 to 75, any type of diabetes, our starting point is moderate intensity statin. I escalate to high intensity if older, longer, complications, or high risk. Let me emphasize that. Older, more than 65 years old. Longer duration, type 2 diabetes more than 10 years or type 1 diabetes for more than 20 years is considered longer duration. Complications, neuropathy, retinopathy, albuminuria, chronic kidney disease, peripheral vascular disease, all of those are complications of diabetes. So if a patient is older, had diabetes for a very long time, had any complications of diabetes, or for the fun of it, you did an ASCVD risk calculation and it's more than 20%, yeah, we are considering high-intensity statin. Okay, let's apply what we just learned on 2 hypothetical cases. I have a feeling you'll ace this. Case 1, 58-year-old man, recent MI with stents 6 months ago. They have chronic kidney disease stage 3. LDL is 124. They are not on any treatment. How do you approach them? So let's go through this. First one, does this patient already have a heart attack, stroke, or peripheral vascular disease? Yes, they had an MI just 6 months ago. So my thinking is high-intensity statin. Okay, should I be super aggressive with them? Well, they had an event just 6 months ago and they have a chronic kidney disease. So they have recent disease and a systemic disease. So yes, we are going to be aggressive with their treatment. What are the targets and things like that? We'll discuss that in the future. Okay, right now our decision is just, do they need it? Yeah, how intense do I need to go is what we decided here. Case 2. 62-year-old female with type 2 diabetes for the last 3 years, now with neuropathy and chronic kidney disease stage 3. LDL is 120, not on lipid-lowering therapy. So let's go through this together again. Do they have a heart attack, stroke, or peripheral vascular disease? Nope. Next, is the LDL more than 190? Nope. Next, are they 40 to 75 years old with any type of diabetes? Yes. So our starting point is moderate intensity statin. Should I go a little more stronger with the statin? Well, let's think about this. Is this patient older than 65? No, they're 62 years old. Do they have diabetes for a very long time? Nah, they just got diagnosed 3 years ago. Do they have any diabetes complications? Yes, they have chronic kidney disease and neuropathy, so they have some complications. So we escalate to high-intensity statin. See, you made these decisions without even opening a risk calculator. Very easy. So here are the take-home points. 1. ASCVD risk stratification matters. It helps you make meaningful, consistent, evidence-based decisions in real clinic time. 2. Screen adults age 20 and older at least every 5 years. Consider annual testing if higher risk. Begin with a non-fasting lipid panel, and you can add on non-HDLC, ApoB, or lipoprotein a selectively to refine risk. 3. Remember the 3 triggers for treatment: clinical ASCVD, LDL more than 190 milligram per deciliter, 40 to 75 years of age with any type of diabetes. Then we're already thinking along the lines of treatment. All right, folks, I'll see you back in 2 weeks with part 2 of this series. Before I sign off, a quick note. This podcast is intended for educational purposes only for clinicians and healthcare professionals. It does not provide medical advice, establish a physician-patient relationship, or replace individualized clinical judgment. Thank you for tuning into Lipid Curious. If today's episode was helpful, consider sharing it with a colleague. You can always reach out to me at hello@lipidcurious.com. Be sure to follow or subscribe so you don't miss what's coming next. Until next time, stay curious and stay confident. Signing off, Dr. Pulipati.